Hi, you have heard of transfusions, maybe dialysis, but have you heard of a technique that selectively removes only harmful elements from your blood? That is therapeutic apheresis. And today on this channel, we will be diving into this topic. So let's get started. Therapeutic apheresis, it aims at removing the pathogenic cells or plasma from the patient and returning the normal component back to the patient. So it helps primarily in alleviating the disease symptoms. Mostly it is used in conjunction with the other treatment modalities. Now that we understand the plasmapheresis, now we see the classification of the therapeutic plasmapheresis. So the plasmapheresis divided into two, plasmapheresis and cytopheresis. So in plasmapheresis, we are removing the plasma, and here the patient plasma is replaced by the fluid like albumin FFP. So it is used commonly in Myasthenia Gravis, GBS and TTP. Then further it is divided as plasma purification, which is done by immunoadsorption, filtration, selection, removal, or LDL apheresis. So if you have know that the LDL apheresis is also known as the lipoprotein apheresis. So this is used to treat the patient with the familial hypercholesterolemia by removing the LDL cholesterol from their bloodstream. Now another one is the cytopheresis, in which we are doing the cell removal or exchange. So it has the erythrocytapheresis, also known as the red cell exchange. So abnormal or infected red blood cells are removed and replaced with healthy donor red cells. It is often used in the condition like sickle cell disease or severe malaria. Next one is the thrombocytopheresis or platelet reduction. So here the removal of platelet in cases of extreme thrombocytosis, such as thrombocythemia, to prevent the thrombotic events. Another is the leukapheresis, that is white cell apheresis. So in this we remove the excess or abnormal white blood cells, especially in leukemia with the high WBC count. It helps reduce the blood viscosity and complication. Now, if you see again that leukapheresis is divided into the photopheresis. So, in photopheresis, it is used commonly in the cutaneous T cell lymphoma and the graft versus host disease. In this technique, we treat the patient white cell with the photosensitizing agent and UV light before infusing them. And then we have WBC for ex vivo immune modulator and the blood stem cell for the bone marrow transplant. Now, we see how the separation works on the apheresis. So the key lies in the highly controlled process of separation, in which a patient blood is withdrawn and passed through a apheresis machine, where it is divided in its core component, red cell, white cell, platelet and plasma. This separation is achieved through one of the two main techniques, either by the centrifugation method or by the filtration. So in centrifugation, the blood is spun at a high speed. Different components settle into layers based on the density. This allows us to selectively remove just the component we want. For example, in GBS, we want to remove the plasma, so we can remove the plasma. And for leukemia, white cells are removed. Whereas in filtration, blood passes through a semi-permeable filter and smaller molecules like antibodies, toxins are removed, while larger components are returned to the patient. Once the target component is removed, the remaining blood is combined and safely returned to the patient, all in a continuous cycle. So based on the indication, we may remove the plasma. It is known as plasmapheresis, red cell, white cell, or even platelets. The beauty of the apheresis is the precision. We only take the harmful substance and give rest right back. There are different categories that will define the therapeutic apheresis. So category 1 is the first line therapy. Either you can use as a primary standalone treatment or with the other modes of the treatment. Category 2 says that it is used as a second line therapy, either as a primary standalone treatment or with other modes of treatment as well, but it is mostly used with the other treatment. Category 3 is the optimum role of apheresis is not yet established. Decision is to be individualized. Category 4 says that the apheresis can be ineffective or harmful, or there is no evidence which can say whether the processes benefited to the patient. Then strength of the evidence. It is also based on the type and the quality. You are seeing the grade on the one side and A, B, C with that grade. So 1 is means the strong recommendation, whereas A stands for high quality evidence, B stands for moderate quality evidence, and C stands for low or very low quality evidence. Grade 2 states for the weak recommendation, and same like in grade 1, A stands for high quality, B is for the moderate, and C is for the low and very low quality evidence. Now therapeutic plasma exchange we will be starting in this video. So therapeutic means we are helping the patient. So it's a therapeutic procedure for removal of the pathological substance. What can be the pathological substance? It can be antibodies, it can be immune complexes or inflammatory mediators. And what are the techniques by which we can achieve to remove the pathological substances? So there can be plasma exchange, double filtration plasmapheresis, immunoadsorption, and LDA-A. So that is low density lipoprotein apheresis. We will discuss the plasmapheresis techniques as we seen in our classification. So the techniques are three. First is plasma exchange, then is double filtration plasmapheresis, and third is immunoadsorption. So in plasma exchange, plasma is separated from the blood by the apheresis, and the plasma is discarded, and it is replaced by the substituted fluid. It can be albumin, it can be FFP or other fluids. Whereas in double filtration plasmapheresis, we use two plasma filters with different pore size. So first we will separate the plasma from the cell, and secondly selectively we will remove the macromolecules, especially immunoglobulins. In immunoadsorption, plasma and cellular elements are separated. So both are getting separated here. Whereas plasma is purified by the column which has the affinity to circulate the immunoglobulins. So it's unlike TPE that doesn't need the replacement fluid. So it won't require any the replacement fluid like FFP or albumin. We always are curious why there are multiple cycles in the plasmapheresis. So this model, which shows the interaction between the intravascular and extravascular compartment, will show the plasma exchange effect and why we require the multiple cycles. So as you see that the substance which need to be removed, it is present in the intravascular compartment, but its concentration is also present in the extravascular compartment in the equilibrium, and this process by which this exchange will happen is known as a diffusion. So when we are targeting any intravascular compartment and do the plasma exchange, the concentration of that substance fall rapidly in the intravascular, but over the time because of the diffusion the concentration of the substance in the intravascular compartment will rise is because of diffusion from the extravascular. That's why we will require the multiple cycle of plasmapheresis for effective treatment. Now, which substance need to be removed? So the substance that is need to be removed should present in the plasma, and that will contribute to the disease or the symptom. It is large enough that it cannot be removed by the dialysis, and it has the prolonged half-life. For example, if you see for IgG, the life is 21 days. It should be acutely toxic or resistant to the conventional therapy, then only you will go with the plasmapheresis. Frequency of the procedure, so it can be disease specific or it will relate to the type of antibody present and the rate at which it equilibrates. So predominantly in the intravascular compartment we'll see the IgM, fibrinogen, alpha 2 macromolecules, whereas in extravascular we will see the IgG and albumin. Now we'll see the Nadler's equation. So this equation, it is used to estimate a person total blood volume. It is based on the height, weight and the sex. So as you are seeing, that patient is male and female. So for the male it is 0.006012 into h cube, that is height cube, divided by 14.6 plus 604 into weight, whereas for a female it is 0.005835 into height cube divided by 15 into weight plus 183. There is another method of calculating, so that is your plasma volume calculation is equals to TBV, that is total blood volume, into 1 minus HCT. So accordingly, how much fluid need to be exchanged. And in that below table, it is given like if you are going with the 3 liters of exchange, then you will be removing about 95% of the plasma. If you are going with 1.5 liters of exchange, then you will be removing about 78% of the plasma. Now, alteration in the blood constituents after one volume of plasma exchange. So, if you see the clotting factor, so the percentage decrease from the baseline is 25 to 30, whereas the percentage of recovery after 48 hours after this procedure is 80 to 100. For fibrinogen, it's 63, but recovery is 65. For immunoglobulin, again same 63, but recovery is 45. For paraprotein, 30 to 60, but recovery is variable. It depends on the patient diagnosis and other conditions. For liver enzyme, 50 to 60 if there is a decrease in the baseline, and the recovery, if you see, it's 100%. For bilirubin, 100% recovery with the decrease of 45. For complement 3, there is 60 to 100% recovery after 48 hours, and there is a decrease in the baseline of 63. For platelets, 25 to 30, whereas recovery is 75 to 100 after 48 hours. Next is the replacement fluid. So as we know, during the therapeutic plasma exchange, we remove a large volume of patient's plasma, which contain essential protein, antibodies and coagulation factors. So to maintain the blood volume and hemodynamic stability, this plasma must be replaced immediately with an appropriate fluid. So here are the examples of the fluid that we can use to replace. So if we are using the crystalloids, so there are different advantages and disadvantages of it. So for crystalloid, it is low cost and there is no risk of disease transmission, but it will not provide any coagulation factor, immunoglobulin, or it is not the hypooncotic. Whereas albumin, it is the most commonly used fluid, but it will not provide any coagulation factor, no immunoglobulin, and it is costly, but there is no risk of disease transmission, and this is isooncotic. So it is usually given in the combination with the saline, and it is preferred in the autoimmune disorders like GBS or MS. For FFPs, if we go, so FFP, it contains the clotting factors, so it will maintain the normal levels of coagulation factor, immunoglobulin and plasma protein, and it will less likely cause the dilutional anemia than albumin. So FFP is used universally for the TTP treatment because it is the only plentiful source of missing ADAMTS 13 enzyme. But there is risk of allergic reaction, TTI and citrate overload. Next one is the plasma protein fracture. It is less expensive than albumin, but it can lead to the hypotensive reaction. Another one is your hetastarch or pentastarch. This one is less expensive than albumin, but it can lead to the allergic pruritic reaction and in the coagulopathy if more than 20 ml per kg is infused in 24 hours. So choosing the right replacement fluid is just as important as the apheresis itself. So it's about balancing the volume, proteins and clotting factors and protecting the patient during and after the procedure. The indication of the plasma exchange according to the ASFA guidelines 2019. So if we are removing the Antibodies. So antibodies can be of two types, allo antibodies and auto antibodies. If you are going with the allo antibodies, in the case of HDN, then it is categorized under three. We have already seen the categorization in the previous slides. Now we are just putting the categories according to the diagnosis. If you are going with the anti-Rh antibodies in pregnant women, then it is again the category 3. For neonatal thrombocytopenia, it is classified under category 4. For autoantibodies, Myasthenia Gravis, category 1. For acute polyneuritis, category 1. For Goodpasture syndrome, it is category 1. If you are going with the removal of the immune complexes, then these are the diseases where we can use. For SLE, category 2. For Wagner granulomatosis, category 2. For cryoglobulinemia, category 1. For RA, it is category 4. For hyperviscosity syndrome, like in Wellstrom macroglobulinemia, it is category 1. For multiple myeloma, due to monoclonal like antibodies like IgG, IgA, IgD, then category 1. For removal of toxins in case of hepatic failure or renal failure, both are categorized as 2. For replacement of deficient plasma component or immune complexes, it is classified as TTP or HUS. For TTP, it is category 1. For HUS, it is category 3. Now, what are the complications of plasmapheresis? So, the complications are subdivided into mild, moderate, or severe as per the Brahmalage et al. So, the mild, it involves skin rashes, paresthesia, restlessness, chills, and rigor, which is short lasting, hardly had a clinical significance, and did not delay in the procedure. Moderate includes your fall in BP, hypotension, tachycardia, nausea, vomiting. Complication due to vascular excess. It's a like a minor type allergy reaction or breathing difficulty. So these complications which requires the medical attention but did not pose any life risk, they fall under moderate complication. Severe, so severe is like your anaphylactic shock, cardiopulmonary complication. They are life threatening events which require to stop the procedure. Adverse effects of TP. So central venous access we will require for this procedures. So it can relate with the infection, septicemia, thrombosis. Sometime if you are going with the subclavian central venous access, then it can lead to pneumothorax as well. If filtration techniques are used, then hemolysis or hypotension may occur. With the use of anticoagulants, like we are using citrate most commonly, so it will lead to hypocalcemia or alteration in the acid base homeostasis, which will cause the metabolic acidosis. Symptoms like hypocalcemia, like paresthesia, muscle cramps, cardiac arrhythmias, and the incidence of causing this is 1.5 to 9%. Now, with the replacement fluids, if you are using albumin, so there is a depletion of the coagulation factor. If you use immunoglobulin, then there is risk of bleeding and infections. So, risk of viral transmission if you are using the FFP. So, accordingly, we have to see. What are the contraindication for this process? It includes your active infection is there, hemodynamic instability, allergic to FFP albumin heparin, and hypocalcemia. Now, where we can evaluate the patient. So, there are two crucial points before the TP. First is your patient diagnosis, and the second is the clinical evaluation for risk factors that may influence the patient ability to tolerate the procedure. So, you have to see the general physical like vital sign, height and weight, vascular excess. Then hematological, you have to look for the CPC where you will see the hemoglobin, hematocrit, platelet count. Then you will check the coagulation status by seeing the PTINR values and anticoagulant therapy on which the patient is, or there's a risk of thrombosis or hypocoagulable state. Then you will look into the cardiopulmonary system, whether there is adequate oxygenation is there, cardiac function is adequate, or there is a history of current cardiac disease, arrhythmias is going on, CADs like coronary artery disease, hemodynamic stability, patient is in sepsis, or patient is having systemic inflammatory response syndrome. So everything need to be looked. Fourth one is your renal and metabolic. So you will assess the volume status, fluid balance, electrolyte abnormalities, and calcium levels. So these need to be correct before starting the procedure. History of renal and hepatic dysfunction. Then you will look for the neurological scene, that patient mental status to participate in the informed consent process. There's a history of seizure or cerebral vascular accidents, autonomic dysfunction or neuropathy impacting the peripheral axis. Then you will look for the medication on which the patient is, whether the patient is an anticoagulant, vasopressor, immunoglobulin preparation, anti-epileptic drugs, protein-bound drugs, allergic. Seventh is like you will see that the disease specific testing, acetylcholine receptor antibodies for the Myasthenia Gravis. So informed consent is required for the procedure. If you found this content helpful, don't forget to like, share, and subscribe to Transfusion Vital, your trusted source for transfusion science and clinical insights. Thank you, and we'll see you in the next video.